treat PTSD because it can lead to a host of other problems, other psychiatric disorders, functional problems, reduced quality of life, and even poor physical health. So why focus on treating PTSD in women veterans? Well, first of all, the number of women who use VA healthcare is growing. In fiscal year 2011, 6% of VA users were women. And if you look at our youngest veterans returning from the wars in Iraq and Afghanistan, it's almost 13% last year. But it's not just the numbers of women using care, it's PTSD itself, because it's a significant concern for women veterans and women in general. In the U.S. general population, women are about more than twice as likely than men to have PTSD. If you can read any of the numbers on the slide, we estimate that the current prevalence of PTSD in women is just over 5% and under 2% in men. If you look at the VA, at veterans from Iraq and Afghanistan, we see the opposite pattern. The prevalence of PTSD is higher in the men. But if you also look at these numbers, and again, if you can see them, 25% in men and almost 19% in women, these are very high numbers. They deserve our attention. Across all of our VA users, we see the same pattern that we see in the civilian population, which is that women are more likely than men to have PTSD. So the context, I'm actually trying to tell you both about an old study and where it's gone in the future. The study we began planning over 10 years ago. And it's very common in healthcare to talk about a gap between evidence and practice. That phrase is overused, but it doesn't make it untrue. And it was certainly the case when we were planning our study. We had the best evidence for cognitive behavioral therapy, CBT, but most VA therapists and most civilian therapists weren't using CBT. They were using other techniques. We chose to study a type of CBT known as prolonged exposure, despite concerns that somehow veterans couldn't tolerate the exposure. It requires repeating a traumatic narrative, or that VA therapists couldn't deliver it because they didn't have necessary training or it wasn't feasible in the VA. At this point, there had been no prior studies of treatment for women veterans. I know that sounds incredible, but that was the context. And in fact, we were the first VA cooperative study to focus exclusively on women. And because I'm here, you probably anticipated the results, which is that the treatment worked. Prolonged exposure was effective. And it was more effective than a comparison treatment that replicated a lot of the kind of techniques that VA therapists were using. So women who got prolonged exposure were more likely to have reduced symptoms. They were 1.8 times more likely to no longer have PTSD. They were 2.4 times more likely to experience complete remission. The study was a big success. And it had important implications for VA healthcare. VA patients, we showed that VA patients could benefit from this treatment and also that it was feasible for VA therapists to deliver it. And this is the point at which the story got kind of exciting for us. VA is a natural translational research environment, and by that I mean that we do the research, but we're also a healthcare system which can facilitate the translation of research findings into clinical care. And that's exactly what happened. So the story, fast forwarding from 2000 to now, is that we have implemented rollouts in the Veterans Health Administration, VHA. We've implemented rollouts of prolonged exposure to train therapists nationwide. We've also added cognitive processing therapy, another type of effective evidence-based treatment for PTSD. Both of these are frontline treatments in the VA-DoD practice guideline. They were reviewed at the highest level by the Institute of Medicine in their report. And at this point, we've trained over 4,400 therapists across the country in one or both of these treatments. Now, I'm happy to say that all medical centers offer either prolonged exposure, cognitive processing therapy, or both. And even had I been here even a few years ago, I couldn't